Everyone, today I am going to explain what is the multiple myeloma. It's a hematological malignancy which is generally presented in old age with the presentation of typical pathological fractures. So what is the multiple myeloma? There is a proliferation of the plasma cells, that is a neoplastic proliferation of the plasma cells. So where the plasma cells is derived from the B lymphocytes after maturation, and the main function of the plasma cells in your body is synthesis of antibodies to fight against infection. So three things are important to know about the multiple myeloma. First is why a name is given multiple myeloma. Myeloma is the collection of the plasma cells, neoplastic tumor cells, and multiple, it means the multiple sites. So that's why it is derived the name, that is the multiple myeloma. It's a collection of the plasma cells and the multiple sites in the bone marrow. First one is. Second one is that there is a suppression of normal immunoglobulin production. Immunoglobulins means antibodies. So antibodies is derived from the plasma cells. In multiple myeloma, the plasma cells is neoplastic, so they are not functioning properly. They are function abnormally. So main function of plasma cells is production of immunoglobulin. So if the plasma cells is neoplastic, they are not able to produce the normal immunoglobulin. So that's why there is a suppression of normal immunoglobulin, so normal antibodies in our body. That's why the patient of multiple myeloma having recurrent infection, because they are not having the normal antibodies to fight against infection. And third one is that there is a production of abnormal protein, that is the M protein or monoclonal protein. Sometimes it is called as a paraprotein because it derived from the single clone of neoplastic plasma cells. That's why we can call it as a paraprotein, and sometimes we can call it multiple myeloma as a paraproteinemia. It's the types of paraproteinemia. Okay. So first we should know about the function of the B cells. So B cells, this is the picture of bone marrow. There is a hematopoietic stem cells. From the hematopoietic stem cells, there is a formation of B cells or the T cells. So after antigenic stimulation, B cells become mature to form the plasma cells. So how the antigenic stimulation can lead to formation of the plasma cells? So in our body there is the APC cell, that is the antigen presenting cells. They present the antigen or their surface and represent that antigen to CD4 cells, that is the helper cells. So after representation, there is a recognition of antigen by TCR, the receptor, T cells receptor present on the surface of the CD4 cells. That is the receptor which is present on the surface, that is the TCR receptor. So after recognition of antigen, there is a stimulation or formation of interleukins. What is the interleukin? Leukin means the white blood cells, and the interleukin is the message between the two white blood cells. Okay. So after antigenic stimulation, the CD4 cells stimulate production of interleukin 2, interleukin 4 and interleukin 5. So interleukin 4 can help to stimulate the B cells production, and interleukin 5 can help to produce the plasma cells from the B cells. That is the maturation of the B cells. So interleukin 4 for stimulation of B cells and interleukin 5 for maturation of B cells into the plasma cells. After maturation, plasma cells synthesize particular antibodies against that particular antigen which is presented by APC on the surface of CD4 cells. Okay, so in this way the plasma cells are formed after antigenic stimulation. But in multiple myeloma, that plasma cells become clonal or become malignant, so they are not able to they are able to form abnormal immunoglobulins, that is the abnormal antibodies. So they are not able to form normal immunoglobulins. Okay, this is the picture of antibodies. This is the heavy chain and this one is the light chain. So what happen in multiple myeloma, in some condition there is a excessive production of this light chain in the body. So we can call it as a Benz-Jones protein. So there is this light chain can deposit in the renal tubules, because they are not generally filtered, they are larger in size, they are not filtered in the renal tubules, and there is a formation of renal failure after deposition of the tubules. Okay, so this can lead to renal failure. So that's why the typical multiple myeloma patient presented with the renal failure. Why? Because there is the excessive light chain production, and that light chain deposit in the renal tubules, and that can lead to renal failure. Okay, so in the case of multiple myeloma, this protein we can call is the M protein. Okay, So antibodies which is generally produced in multiple myeloma is IgG types, sometime IgM, and third antibodies is IgA type. So multiple myeloma, there is a formation of M protein, that is the neoplastic proliferation of abnormal protein, that is the paraprotein, and the protein is typical M protein, which is generally synthesis antibodies like IgG or IgM. Either they synthesize IgG, IgM, Ig or sometime IgA. IgE presentation is very rare. Okay, what are the recent criteria to diagnose the multiple myeloma according to WHO? So more than 10% of the plasma cells become clonal. More than 10% of the plasma cells, clonal plasma cells. What is the meaning of clonal plasma cells? Clonal plasma cells is derived from the single clone, that is the monoclonality. Monoclonality is the sign of neoplastic cells. So that should be confirmed by the flow cytometer, because the monoclonality means either they secrete light chain, lumbar chain, or kappa chain. So either they secrete lambda chain or kappa chain. So that means the cells are derived from the single clone. And second one is the plasmacytoma, which is confirmed by the bone marrow biopsy. What is the plasmacytoma? There is a focal collection of the plasma cells in the bone marrow, and that bone marrow that is proved on the bone marrow biopsy. That is the plasmacytoma. So more than 10%. Earlier, more than 30% is considered sufficient to call it as a multiple myeloma. Now they reduce the number from 30% to 10%. Clonal, but it should be clonal in origin. Second one is the M protein in either serum or the urine. M protein, which is generally detected by serum protein electrophoresis or urine protein electrophoresis. And third one is the most important, is the end organ damage evidences like a CRAB. C means a hypercalcemia, increased serum calcium. Why there is an increased serum calcium in multiple myeloma? Because in multiple myeloma there is this excessive secretion, excessive stimulation of osteoclast. There are two types of cell in the bone marrow. First one is the osteoclast, second one is the osteoblast. So osteoblast is helpful in healing of the bone or repairing of formation of the new bones, and osteoclast, the main function of osteoclast is to dissolve the existing bone and increase the serum calcium level. Okay, so there is a hypercalcemia because the excessive osteoclast production, and that osteoclast lies the normal bone, and that's why there is the formation of pathological fracture in multiple myeloma, because there is a excessive osteoclast production. Second one is the renal failure. As I already told you why there is a renal failure, because the deposition of light chain in the renal tubules. Third one is the anemia. There is a two reason for anemia in multiple myeloma. First one is there is the excessive proliferation of the plasma cells. That plasma cells replace the normal hematopoietic cells, that is the cells of the bone marrow which produce the normal blood in our body. So there is a excessive proliferation of the plasma cells that entirely replace the bone marrow. Second one is that there is a renal failure and decrease the erythropoietin production. Erythropoietin is helpful in erythropoiesis. Erythropoiesis means the production of normal blood in our body. So erythropoietin decrease, and second one is the replacement of normal hematopoietic cells by the plasma cell. Okay, and third one is the multiple bone lesions. Why there is a multiple bone lesion? There because there is a excessive activity of osteoclast. So what is the presentation of the multiple myeloma patient? Generally in the 5th to 6th decade, okay, mostly after 50 or 60 year of age, patient presented with the multiple bony fractures or the bone pains because of the osteoclast activity. As the osteoclast is activated, there is an increased serum calcium level, that is the hypercalcemia. Deposition of light chain can lead to Benz-Jones, that will lead to renal failure. Okay, so osteoclast can lead to pathological fracture, and these two things are correlated, that is the hypergammaglobulinemia, increase excessive antibodies production, but that antibodies is not function properly. That's why patient is having recurrent infection. Okay, and the most important, sometimes amyloidosis may be presented with the multiple myeloma. what is the main pathological cause, what is the main causes of amyloidosis, what is the pathology behind the amyloidosis. Amyloidosis is nothing but the extracellular protein deposition. Okay, in our body there is a one protein called the chaperone protein, which the main function of chaperone is to folding of protein. But in case of multiple myeloma, there is excessive production of proteins, so chaperone is overburdened, overloaded, and that not function properly after a particular time. So that can lead to unfolded protein can deposit on the extracellular. So there is a extracellular deposition of protein that can lead to amyloidosis. Okay, and most important is the elevated ESR. Why there is a ESR elevation? ESR is the erythrocytic sedimentation rate. We put our RBC on the one tube and we measure the rate of sedimentation. Okay, generally RBC is having negative charge on the surface, so they are repel each other, so they are not sedimented into the normal tube. But in case of multiple myeloma, there is a presence of M protein. M protein is positively charged, that neutralize the negative charge of the RBC, and that RBC sediment very fast. So there is a increased erythrocyte sedimentation rate. That's why increase ESR. Generally ESR is presented in increase in inflammatory conditions. Okay, that one is the older criteria. As I told you, more than 30% is the older criteria. Now they replace the more than 10%. First one is the plasmacytoma confirmed by the bone marrow biopsy, and third one is a measurement of IgG and IgA level in the serum or urine. Okay, what is the pathogenesis of multiple myeloma? It is a genetical origin. First one is the antigenic exposed post-germinal B cells. That is the first one is the B cells which is already antigenic exposed. As I told you, antigen presenting cells presented antigen to the CD4 cells. That CD4 cells can lead to maturation, stimulation and maturation of B cells into the plasma cells, and that B cell that is already antigen exposed, there is a deletion of chromosome 13 or translocation of 14q32 chromosome that lead to formation of MGUS, that is monoclonal gammopathy of undetermined significance. Why we can call it is a undetermined significance? Because MGUS sometime, not always, can lead to multiple myeloma. Okay, so there is a multiple myeloma conversion from MGUS. Not all the patients. So we are not able to decide which patient convert MGUS to multiple myeloma, or which patient are not able to convert MGUS from to multiple myeloma. So that is the undetermined significance. Okay. After MGUS, there is a second mutation. We can call it as second hit. This is the first hit, that is the second hit. So second hit is a RAS mutation, P53 suppression, P16 methylation, and the MYC abnormality. This can lead to the multiple myeloma. So the origin of multiple myeloma is always genetical, or sometimes always genetical. There is a chromosomal abnormality. The cause can be viral infection, can be a radiation exposure, can be a chemical exposure. Anything can cause this genetical abnormality. Okay. So what happens after clonal transformation of plasma cells? Once the plasma cells become neoplastic, they secrete two types of factor. First, there are the two types of cells in our bone, osteoblast and osteoclast. So osteoblast, there is a suppression of osteoblast and there is a stimulation of the osteoclast. So osteoblast, suppression of osteoblast can lead to failure of repair of the bone, and osteoclast lead to bone resorption. There is a excessive destruction of the bone that not able to repair because of the suppression of the osteoblast. This can lead to multiple osteolysis or osteolytic lesions, and finally pathological fracture. Okay, that's why the patient of multiple myeloma always presented with the multiple bone pain, osteolytic lesion on the X-ray, or pathological fractures. So main pathogenesis, there is the formation of interleukin 6 that activate two types of signaling pathway, JAK-STAT pathway. Second one is the RAS-MAP kinase pathway. So JAK-STAT is the anti-apoptotic pathway. Normally our cells destruction their own cells after they cross the certain age limit. So our body can lead to apoptosis of the certain cells after particular time, like our skin epithelium are changing after 35 days, or intestinal mucosa changing after every 1 week. So they lead to destruction of their own cells by apoptosis. But the JAK-STAT is the anti-apoptotic that prevent the cells from destruction, that is the anti-apoptotic. Second one is the RAS-MAP kinase pathway. There is a transcription factor that means that lead to proliferation of cells. The final result is the proliferation of the plasma cells which secrete vascular endothelial growth factor, and there is a formation of new blood vessel, that is the angiogenesis. Okay, after proliferation they secrete the interleukin 6, and that is the vicious cycle again continue to next level. Okay, now what is the investigation in the case of multiple myeloma? Generally blood, second one is the bone marrow, third one is the serum or urine electrophoresis, and the final is the skeleton radiological survey and the skeleton MRI to detect the multiple osteolytic lesions. So what is the important in blood and bone marrow? In the blood there is a CBC. First one is there is a peripheral smear, ESR finding, and the bone marrow there is a demonstration of the plasma cells clonality by immunophenotyping, that is means by flow cytometer, and serum and urine electrophoresis to detect the M protein in the urine and the serum. Okay, now this is the multiple lytic lesions on the skull of the patient of multiple myeloma. This is the same picture, this is the different picture of lytic lesions in the pelvic region. Okay, now this next picture is the multiple osteolytic lesions in radius and ulna, multiple lesions in the case of osteolytis. Now come to the peripheral examination. Peripheral examination, the most important is the bluish background. Why there is the bluish background? Because the presence of excessive M protein that gives the bluish background. Second one is that there is a rouleau formation. What is the rouleau formation? There is the stack of coin appearance, because that is the RBC clump to each other. Why there is the RBC that stick to each other? Because as I told you earlier, RBC is having negative charge, that's why they repel each other, that's why they are not stick generally to each other in routine. But in the case of multiple myeloma, there is the excessive formation of M protein. M protein is the positively charged protein neutralize the negative charge of the RBC, and that's why the RBC stick together, because they are not having negative charge on their surface. So there is a formation of rouleau formation. That is the typical rouleau formation. That one is the lymphocyte, and this tiny dots is the platelet. Okay, this is the bone marrow picture. So how the plasma cells look on the bone marrow? That is the bluish cytoplasm, eccentric nucleus, and perinuclear half. This is the three important characteristic. And this one is a prominent nucleus showing the immature plasma cells. As the plasma cells become mature, they lost their prominent nucleoli. Okay, this is the same picture of bone marrow biopsy, same patient with the bone marrow biopsy. Okay, the same picture again. That is a typical perinuclear half. Suppose this is the plasma cells, so there is the eccentric nucleus, and that is the clearing, that is the perinuclear half. Okay, next is the sheets of the plasma cells with some cells showing the prominent nucleoli, that is the immature cells. Some cells showing binuclearity, means the nucleus is divided into the two lobes, that is the immature cells, immature plasma cells. Okay, there is some inclusions body are presented like Dutcher body, that is the nucleus inclusion, some tiny white dots in the nucleus. Russell body, some eosinophilic material in the cytoplasm, and third one is the Mott cells, that is the multiple inclusions, grape-like structures in the cytoplasm. So this one is the typical Mott cells in the multiple myeloma. So multiple grape-like small tiny dots in the cytoplasm and the binucleus cells. Okay, now come to the serum electrophoresis. Serum electrophoresis detected the M protein in the case of multiple myeloma. So multiple myeloma, the plasma cells can be polyclonal or can be multiclonal. So when we get the polyclonal cells in the case of inflammatory condition, not in neoplastic condition like TB, rheumatic arthritis, ulcerative colitis, any inflammatory condition in which lead to there is a formation of the antibodies. from the plasma cells. So we will get the broad band in the gamma regions in the case of polyclonality. In case of multiclonality, we can get dense, well localized narrow band, especially in the gamma region. We can call it the M protein or M spike or M band. M means multiple or multiple myeloma protein. Okay, this is the general electrophoresis. We can connect it as a positive charge or negative charge, and there is a formation of band. There is a formation of albumin because albumin is predominated protein in our body, and there is a globulin alpha 1, alpha 2, beta and gamma. So there is a prominent band of albumin and very thin or very light color band of gamma 1, alpha 1, alpha 2, beta and gamma. So this is the normal picture of normal patient. We can get normal albumin, which is intensely dark in color, and very light alpha 1, alpha 2, beta and gamma. So in case of polyclonal hypergammaglobulinemia, means in case of infection or inflammation, we can get broad band of at the region of gamma, that is very broad band of gamma region. So this third picture is multiple myeloma. We can get M protein or M spike, that is a densely red color dot or band in the gamma region. Albumin is also intensely dark albumin, and we can call it as a gamma region. We can call it as a M protein or M spike. So that is the electrophoresis. We can get the albumin, alpha 1, alpha 2, beta, and that is the gamma. So increase gamma, that is the M protein on the gamma region. So next one is the flow cytometer. We can also detect the multiple myeloma in flow cytometer. Generally cells having some proteins on their surface, as every cells having protein and on their surface, and that protein is detected by the flow cytometer. So the protein which is presented on the surface of the plasma cells is the CD38 and CD138. Which one is 38 and 138, which is detected by flow cytometer. So that is typically positive. CD38, here is also CD38 positive. So CD38, 138 both are positive in multiple myeloma. So next come to the treatment. Treatment is basically divided into two categories. First one is either the patient is having under the age of 65 year or over the age of 65 year. So if the patient is under the 65 year, the patient is prescribing chemotherapy, that is a bortezomib. What is the function of bortezomib? Is the proteasomes inhibitor. Proteasomes inhibitors. What is the function of proteasomes? Proteasomes break down the protein. But in case of multiple myeloma, our body produce certain protein that kill the particular plasma cells, neoplastic plasma cells. So our main target is to inhibit the proteasomes that degrade the protein that kill the multiple myeloma cells. Okay, so bortezomib is the first line of treatment, that is the proteasomes inhibitor. Second one is the steroid combination, lenalidomides with the dexamethasone, that is the steroid. Lenalidomides having anti-osteoclastic activity, that is they prevent the excessive stimulation of osteoclasts, and second is also having anti-angiogenic activity, that is that also prevent the new vessels formation, that create the microenvironment, favorable microenvironment for plasma cells to grow. So there is two main drugs, chemotherapeutic drugs, and the third, if the patient is having resistance to that chemotherapeutic drug, so the final treatment is the autologous hematopoietic stem cell transplantation. Okay, second one is if the patient is over the age of 65 years, the more aggressive drug, that is the melphalan, which can cause bone marrow suppression, is given to the patient along with the steroid, that is the prednisolone. Okay, thank you.